So I have the pleasure of talking to you today about something that is neuro-ophthalmic rather than neuroimmunologic. And I think you're going to enjoy hearing about what we're doing with the new instrument in the clinic and how this instrument called Ocular Coherence Tomography is being used to help us in the care of MS patients. So what I want to get through to you today is to explain to you what is OCT, or Ocular Coherence Tomography. More importantly, why, not what, why do we perform OCT on MS patients? Okay, and that's three major reasons. One is to evaluate damage to the optic nerve. The second is to evaluate retinal abnormalities, which you'll hear about are associated with MS therapies, and potentially to detect new pathologies that are evident in the eyes of MS patients that may help us clarify different subsets of patients. And finally, to put this test into perspective in terms of what you may be seeing in the future with the use of OCT in terms of monitoring the disease and in terms of a model to help us develop new compounds for protecting brain from injury. So you're thinking, what in the hell are we looking at the eye for when the problem's in the brain? Well, simply, in MS, when people have pathology of the optic nerve, and many of you have had optic neuritis or inflammation of the optic nerve, which is the most common presenting sign of multiple sclerosis and happens in about 70% of all MS patients, the optic nerve is experiencing the same inflammatory injury that occurs in any other lesion in the MS brain. And in particular, this is a mixed injury that you've heard about that involves immune cells and involves humoral factors such as antibodies and proteins that communicate between cells such as cytokines. But more importantly, this injury not only involves the white matter, the oligodendrocyte, which can be shown here as stained in red, the coverings of the nerves, but there is also axonal damage, damage to the neurons themselves, or the cables that these nerve cells are using to communicate with one another. And why we're concerned about this axonal damage is once you cut the wires, you can't get it back. And once you've injured these nerve cells, they contribute to permanent problems eventually that lead to permanent neurologic deficits. And so the problem when we're dealing with the brain and we're dealing with nerve cells that are cut as shown here in these green blobs and were initially known about way back in 1915 is that it's hard to measure what the extent of that injury is separated from the injury to the myelin or the white matter. But when we do OCT and we're measuring the front of the eye here, through the eye into the retina and the beginnings of what we see as the front of the optic nerve, that white matter or myelin is only gathered up by the nerves after all these cables from cells inside the eye that are producing the cables that make the optic nerve exit the eye. And so when we have this look back here into the retina, in which the very top layer of the retina is all the cables that are composing the optic nerve here in this image from OCT, we're seeing those cables without the white matter. And so when we anatomically measure this layer right here, which we call the retinal nerve fiber layer, we're getting carte blanche view of the amount of cables that make up the optic nerve without the mess of having to figure out how much of that tissue is white matter or myelin. So this is our ability to measure axons free of all the noisy information that comes from having to measure the damage to the covering of those axons. And also, we can point this OCT machine away from around the optic nerve, this area here, and onto the retina, and be able to get, as you can see, very sharp images that can tell us about other retinal problems. So that's why we're looking in the eye to tell you something about what's going on in your brain in this disease, because the injury to the optic nerve is something we can measure in a very sensitive way, the axonal compartment, by looking inside the eye at the very origins of the optic nerve. So how does OCT work? Well, basically, a near-infrared light source is shined through a beam-splitting mirror, bounces off the back of your retina, is compared with a comparator light source going off another mirror in the other direction, and the differences in the coherence of the light forms are then deconvolved into an image of the surface of your eye. I know that makes absolutely perfect sense, so I boiled down the technology simply into this. We have an OCT machine here. Many of you have had your chin on this machine for one reason or another. And we use what's called, as Dr. Eva would say, a laser, okay? A laser is then transmitted to the back of your eye, and a bunch of robotic elves then pound out an algorithm and give us a pretty picture, okay? So basically, if you can think about it in these three simple steps, you have the idea of the high technology of OCT. Why we use OCT rather than other instruments is this. When we want to image something, our resolution, how sharp a picture we can get, is dependent on the wavelength of the light. And when we use larger wavelengths, such as ultrasounds that we use in many medical procedures, that larger wavelength can give us a better penetration into tissues. We can image deeper down, but the resolution of the image is limited. However, if we use a light source, again, a longer wavelength of light, near infrared, we can't penetrate deeply, but the good thing that is the eye is a clear ocular instrument. We can get light in and receive it back. The retina isn't that thick, and we can get that information out and get a resolution at the micron level. So that's what ocular coherence tomography is and why we use it. But why do we use it in a clinical situation? 3 reasons. Number one is we want to measure that innermost layer of the retina, the retinal nerve fiber layer that has the axons that compose the optic nerve. And by measuring that axon, we can measure the amount of optic nerve injury that's occurred. Second, we can point the OCT at the nearby retina, and we can look at issues of retinal pathology, and in particular, for most of you who may be on a medication called fingolimod or Gilenya, one of the rare complications of that medication is swelling of the retina, and we want to be able to detect that as soon as possible. Finally, we're starting to understand as we look at more and more MS patients that there may be other funny business going on in the retina that we didn't expect to see. And in particular, I'm going to talk to you about 2 things: degeneration of the retina that we see in some MS patients, and also retinal cysts, or accumulations of fluid that we can see in layers of the retina that may be able to help us gauge a certain level of MS activity. So, if we're going to use this to measure optic nerve injury, you might be saying, hey, I had optic neuritis and I got better. Are you really expecting to see a lot of damage that goes on because people have optic neuritis? Well, it ends up that the answer is yes. When we look at people who have optic neuritis and we use this instrument to measure the thickness of the cables that compose the optic nerve, we find out that people who have had optic neuritis in an eye, shown by this column, which is on average about 80 microns thick. Think of a normal optic nerve as having an average thickness of about 100 microns. We notice that the average loss of optic nerve cables after an episode of optic neuritis is about 20% or 20 microns, despite the fact that 95% of people recover. More importantly, and interestingly enough, we also find out that when people have optic neuritis in one eye, the fellow eye is injured a little bit. And in people who have MS who've never had optic neuritis, we find out that their optic nerve cables, those axons, are thinner than the average population. And we're going to get back to that as why it's important, but we can detect this cable loss despite the fact that people recover. And part of that is the brain being able to compensate. Part of that is the fact that we have probably more optic nerve than we need. We have a little safety room. And this points it out a little bit further. If we look at how much you lose this retinal nerve fiber layer, eventually, if you lose too much, your vision starts to drop. But there's two curves here to this vision loss, and essentially, you have room to spare. You're starting out here with 100 microns. You can lose about 30% of that optic nerve until you start hitting the slippery slope, okay? Once you start losing more than about 30% of your optic nerve, the more you lose, the more vision seems to drop directly proportional with that. And there are some caveats to that, but this is important for us as clinicians because if you have another event of optic neuritis in the same eye, you went from here to here with the first event. If you start having the second event, you're not going to necessarily recover as well as you did in that first event. So we have a correlation between vision and optic nerve loss. It's not perfect. There's also a timing issue. So when we look at the retinal nerve fiber layer in optic neuritis, we have to be concerned about when we look at it in order to measure the amount of loss. This is an MRI scan of a right optic nerve that has optic neuritis here. This is where the injury is occurring, well behind the eyeball, which is where we're measuring that thickness with OCT. The cell is here. It's sending its cables all the way back to the brain this way. So when you have your injury here, this cable has to degenerate back to the source in order for us to see the damage that's happened. And this graph shows it right here. At the time of optic neuritis, you don't see this nerve start to get thinner until, on average, 3 to 6 months for this dying back process to occur. So often, if you're having your optic neuritis and you rush in and you say, hey, is this going to be bad? Turn on the switch there. Let me get my eye in front of that laser and let's take a look. The idea is it's too early. We can't see how much damage has happened using this instrument until enough time has passed. But what information do we get? This is the nice sheet of paper that's delivered by the machine, and an example is a patient here with left eye optic neuritis. OD means right eye, OS means left eye. It's secret code, but now you know it. All right. This is the picture, essentially, that we're getting delivered, magnified up here, of the optic nerve as the cables are diving down here to form the nerve. And this is the area off of the nerve that we're measuring. And this is the retinal nerve fiber layer in red. That is the thickness of the layer that we're measuring. And we're measuring a 360-degree circle, starting here and measuring clockwise around, getting you an average thickness at each point around. And because more cables enter into the top and the bottom of the nerve because of the construction, you have these two hills that are natural to have thicker optic nerve in the top and the bottom of the nerve. So the machine tells us what the average thickness is of both nerves. So it calculates all the way around the circle and then averages the number. That's that 100 number I gave you. It also tells us a breakdown of, in each quadrant, superior, inferior, temporal, nasal, how much that thickness compares to the normal population. And this is important not because it tells us exactly a relationship with vision, but because there are certain patterns. Most optic neuritis in MS tends to have loss in this temporal region, extending out superiorly and inferiorly. Some other disorders like neuromyelitis optica tend to affect the superior and temporal portions of the nerve. And finally, it gives us a quality control. We have to look at where the machine is saying it maps out this layer and make sure it's doing an accurate job. It also does a quality control job on you as well, but we won't talk about what it's reporting about you. But it tells us if you were keeping your eyes still, etc. So, with OCT and optic neuritis, can OCT diagnose acute optic neuritis? How many people say yes? How many people say no? All right, you're listening. Good. The answer is no, because as we talked about, the changes are delayed from the time that you have optic neuritis to the time we can measure it with the OCT machine. Can OCT detect prior optic neuritis or optic nerve injury? Yes. Good. But we need about 3 to 6 months to see that injury. We can also detect injury to the fellow eye, and we're going to talk about a little bit later why this may be important. Can OCT predict vision after optic neuritis? Yes? How many people say no? You're both right, okay? Yes and no. Because axon loss is not everything. As I showed you, axon loss can predict the amount of vision, but the extent and even the region that's affected isn't this one-to-one relationship that's absolutely perfect. And that's because white matter injury also stinks, okay? It's not good for delay your transmission and to interrupt that transmission back to the brain. And so both of these factors contribute. And if you look at the amount of information overall that OCT provides, it maybe is about 40 to 30% of the overall information to explain your vision loss. It correlates, but it's not everything. And we can use that to sort of gauge a certain situation, and that is, if you haven't had good recovery after optic neuritis, and it's been enough time at that 3 to 6 month level, we can take a look at how many cables have been lost. And in that situation, if there's a discordancy, that is, the amount of cables you've lost really isn't that much, but your vision still stinks, then we can get a little bit more aggressive, thinking that the demyelination or the inflammation may not be responding well to therapy, and that's when we can go to bigger things than just steroids to try to speed up the recovery. And so OCT can be helpful in that extent to looking at more aggressive and potentially hazardous interventions like plasma exchange to help make the vision get better. Why else do we use OCT? We use OCT to find swelling in the retina, what we call macular edema. And macular edema is associated with one of our MS therapies, oral fingolimod or Gilenya. And in fact, that side effect of macular swelling, which generally goes away when you stop the drug, is less common as you go to our current dosage of the drug, 0.5 milligrams. And as you see here in this chart, the incidence can go up almost 5-fold when you use higher doses of this drug, is that this macular edema is something we don't want to miss because we need to stop therapy in order to let it spontaneously recover. Its onset is generally within the first 4 months of treatment. So the rule in the clinic is you get a scan beforehand. Why do we want to scan beforehand? Make sure your retina is normal to begin with. Make sure you don't have any other retinal problems, such as swelling you don't know about. And believe me, since I read them all, I've seen more problems in other people's retinas that have nothing to do with this drug than I've seen any problems with the drug. So sometimes you're getting that scan and I'm reporting back to your doctors, hey, did you bother to take a look or send this someone to an ophthalmologist because they've got a problem going on in their retina that's a little bit more important than just do they have swelling. The second is we know that if you have inflammation in the eye or have other conditions like diabetes, you may be more predisposed for that, for this complication, and we can detect those problems with the OCT machine. The symptoms of macular edema with oral fingolimod, to keep in mind, are painless vision loss. It's usually insidious rather than rapid, such as with optic neuritis, and usually color vision isn't as affected as strongly as it is with optic neuritis. So those are things to keep in mind if you're on oral fingolimod and you're curious as to whether any vision change is potentially due to this or due to a new event of optic neuritis. And finally, how we treat it is you just stop the medication. And in most cases, 80+% or more times, it fully resolves. So another reason why we are doing OCT is we're finding out new pathologies that are in the back of the eye. And this is one recent publication that shows in a fraction of MS patients, when we look at that macula, that retinal area, not around the optic nerve, we can see little pockets of fluid. The thought control arrows here are showing you where those pockets of fluid are in the retina. So these are called microcysts, little pockets of fluid. And why it is interesting to find these microcysts is, as the authors pointed out, it's not in all MS patients. We only find it in about 5% of MS patients. But it is associated with worse vision, partly because it's not good to have fluid in your retina. So if you have a hard enough time getting the signals back, if you're trying to look through a retina that's full of fluid instead of being optically clear, it degrades your vision. And second of all, the patients who had this, they tended to show increased severity of their MS, higher activity measures of their MS, such as both on MRI and clinical relapses. And so now we're looking at measuring the OCT of the retina, looking at these patients who have this and seeing if it's predictive of disease activity. Because when you have the microcyst, you have worse vision, you have higher disease activity, but we also noticed that the people who had these microcysts before the fluid developed, we could see a little bit of thickening in that region. And so perhaps if we see that thickening develop in some people, we may be able to gauge that the disease is revving up. The other thing that we've seen in OCT is retinal degeneration. So again, looking off the optic nerve at the retina, this is the normal macula, the most sharp area of vision you have in the retina. This is the fovea. This is where you're trying to drive your visual focus at any one time, because in the fovea, as you notice here, the nerve fiber layer, the nerve cells that produce the nerve fiber layer, the ganglion cells, all those other cells are pushed out of the way. Light has carte blanche access right to your photoreceptors here. That's your sharpest part of vision. So here, there are no nerve cells, no nerve fiber layer to measure. And so if we look at someone who's had optic neuritis, and I apologize that this is a little bit blurry, but this is the OCT measure I showed you around the optic nerve, and this is the OCT measure of the thickness in this region at the macula. The cells here, the ganglion cells, are the ones producing the cables that make up the nerve fiber layer around the optic nerve. So when you have optic neuritis, as shown here in this left eye, naturally you develop thinning in the macula here because those cells right here that are producing these cables are dying because they've been injured. But you notice right here in the smack dab center, which is right here, there's no thinning because there are no nerve cells there. It's all the light sensing cells or the photoreceptor cells. But we notice that in a subset of MS patients with no optic neuritis, notice here, nice, happy, healthy green, okay? It's all thin here. So this retina is thinning. Nerve cells are dying in the retina, despite the fact that there's no evidence of optic nerve injury. It's not a secondary effect of optic neuritis. It's a primary retinal degeneration. And this we've noticed in about 10% of MS patients. Again, they have worse visual acuity, not surprising since the retina is thinner. If you actually look at retinal function, it's worse. And it tends to be associated with a disease progression. And this may be a subtype of progressive MS and something that helps us understand neuronal degeneration that's going on in the brain. And there are ongoing studies to look at that correlation between what we call cortical atrophy, brain atrophy, and this progressive type of MS. So what are the future uses of OCT in MS? Talk to you about what we're doing right now. You've heard about this progressive retinal atrophy. You've heard about the microcystic edema. So these are new pathologies that may bring OCT into the regular use to surveil for disease activity and to surveil for subtypes of patients that may respond or not respond well to therapies. What I want to talk to you now about is how we can use OCT potentially in the future to gauge therapeutic response, and how we might be able to use OCT to measure drugs that help protect brain. Not that are directly related to disease control, but the idea is if we can give a drug that makes less neurons die than would otherwise die, it's best to have more brain than less brain, a general mantra we go by in neurology. Okay? So if we're going to have something that gauges therapeutic response in MS, we better be able to use this instrument to analyze everyone. And as I told you, it's good for people who have optic neuritis, but the point is, what happens if you never had optic neuritis? How good is it? Well, it ends up to be surprisingly very good. That is, are the eyes the window into the soul? Well, the OCT machine says pretty much yes. Okay? And how common is retinal nerve fiber layer loss as we measure the amount of cables that make up the optic nerve? I showed you before that if you've had optic neuritis, you have a thin optic nerve compared to normal individuals. But if you've never had optic neuritis, you still have thin optic nerves compared to normal individuals. And if you're the fellow eye of an eye that's had optic neuritis, you're a little bit worse, because the inflammation that gave you the initial optic neuritis really wasn't so isolated. It generally affects both eyes. It's just that in one eye, it's bad enough to cause clinical symptoms, and in the other eye, it didn't reach that level of severity. But also, what's more important is it better be present in all forms of MS. And here you have patients with relapsing remitting disease, patients with primary progressive disease, and patients with secondary progressive disease. So no matter how much we chop up this disease, whether you've had optic neuritis or haven't had optic neuritis, whether you have relapsing disease or progressive disease, we find changes on your OCT. So far, so good. We can use this to gauge therapeutic response only if we get information from everybody, not just people who've had optic nerve problems. And the OCT says no matter who we look at with MS, there's a problem going on. Second is, what does it correlate with? Okay? Well, interestingly enough, the amount of loss going on in your eye ends up being proportional to the amount of loss going on in your brain. So just by shining a light and looking at the proportion of retinal nerve fiber layer loss, here you can see mild loss getting worse and worse, and the associated brain scan where this is brain parenchymal fraction. So it's just a percentage of how much of the volume of your skull is composed of brain. And here you can see that fraction going down in proportion with the shrinkage of the optic nerve. So now we have two elements that we want to see. We have a measure that can be applicable to everyone, and we now also have a measure that correlates with something that's very difficult to capture otherwise. That is brain atrophy, which is a strong measure of disability in MS. Why is brain atrophy hard to do? Because we've got to do a lot of MRI scans, and then the harder component comes in is we've got to have someone who actually does a lot of fancy manipulations and measures it. And radiologists don't want to do that. So we never get this information outside of clinical trials. So, and OCT is about 6 to 7 times less the cost than an MRI scan. So now we've got those two components. We've got a relationship, we've got access to everyone, but the question is this going on independent of you having attacks? That is, the reason these brains could be so shrunken and these nerves so shrunken here is that these people are having the most episodes of optic neuritis, and you have a lot here going on, you have a lot here going on. Well, it ends up, we look over time, we find that this retinal nerve fiber layer thins over time in MS patients. So if we want to have a measure of how your therapy is doing, how it's protecting brain from further shrinkage, we want to see, does it change over time? And it ends up that the retinal nerve fiber layer thins over time. With 3 or more years, we can see up to 6 microns of loss in an MRI scan, in the OCT scan. You may say this is fine, but these are people having optic neuritis. Of course it's shrinking. Well, if we cull out those people who've never had optic neuritis, we still see this shrinkage over time. So now we have a metric of retinal nerve fiber layer loss that correlates with brain loss that we can potentially use to measure how effective a therapy may be in terms of preventing neuronal loss and hopefully disability. Now, with all that said and done, the problem is right now is we don't know how good that prevention should be right now. How good can we expect any therapy to be? We're getting those numbers, and once we do, we'll have an idea of what is the rate that naturally happens in MS, what's the rate that happens in someone who's on treatment who's being controlled, and then get an idea if there's a line in the sand that we do this scan in, that if you're crossing, it's a sign that you're not responding to your therapy. We're also getting better with our OCTs. We have what's called spectral domain OCT, which gives us prettier pictures than ever before. It allows us to track you, so when you get bored of looking at the light for a couple seconds, the machine can turn off and return on and ignore your ignorance of following directions. It has high signal-to-noise reduction, and it allows us, more importantly, to identify the individual sublayers of the retina. Why is that important? Is because, as I told you, we've been looking at this layer of cables. But sometimes we can't tell if that layer is thinner because you've actually lost cables, or maybe the cables are just shrunken and thinned down. But we can look at the cells that are making these cables, the ganglion cells that are sending these cables out to form the optic nerve. And if this layer is thinner, we know that we not only have cable loss, we have actual nerve cell loss, which is what we don't want to see. And when we look at ganglion cell loss after optic neuritis, we find out that when you have optic neuritis, you get retinal nerve fiber layer loss, as shown in the affected eye here. This is the thickness at baseline, and you can see it getting thinner 3 and 6 months afterwards. But notice if we look at the ganglion cell loss, we find out that the ganglion cell loss occurs also at a similar time period. So you're losing nerve cells as well. And this happens and is more significant at 3 months than we see with retinal nerve fiber layer loss. So by segmenting the retina, we may have a more sensitive indicator of nerve cell loss, and something that even shows itself a little bit sooner than retinal nerve fiber layer loss does. And when we look at the correlation between ganglion cell loss and vision, we find out that this correlation, the tightness of these dots around the line, is better for ganglion cell loss than nerve fiber layer loss. So segmentation is going to give us a more powerful measure, perhaps, of something related to visual outcome, as well as measuring the amount of injury that happens over time. Finally, I mentioned neuroprotection as a reason to use OCT. And the goal is to not prevent permanent vision loss by protecting these ganglion cells from dying. And the other important benefit is if we find something that's neuroprotective in the eye, that is, we're all losing in disease our retinal ganglion cells here, we want to give a drug that makes this slope milder, so that over time you're using less and less neurons. The gap here between these two lines is the amount of nerve cells that are being protected at any one point in time. Because sooner or later, once you hit a bottom line of ganglion cell loss, you get vision impairment. So what is neuroprotection like? I'll give this nice analogy from Cliff Clavin, for many of you who might mention him from Cheers. This was kindly provided by Bob Surgott, a colleague of mine. And Cliff can explain neuroprotection to you quite well. Cliff tells Norm, it's like this. A herd of buffalo can only move as fast as the slowest buffalo. So when the herd is hunted, the slowest and weakest ones at the back are killed first. This natural selection is good for the herd as the whole speed and health of the group is improved because of the regular killing of the weakest members. In much the same way, the human brain can only operate as fast as the slowest brain cells. Excessive intake of alcohol kills brain cells, as we know, but of course it attacks the slowest and weakest brain cells first. In this way, the regular consumption of alcohol eliminates the weaker brain cells, making the brain a faster and more efficient machine. That's why you always feel smarter after a few beers, okay? So our job in neuroprotection is essentially not the Cliff Clavin strategy to kill off the weakest and slowest of your brain cells, but to protect all of them. And so, as we talked about, the idea is you have an average number of nerve fiber layers, thickness at 100 microns, and think of this. One attack of optic neuritis, which reduces your thickness about 20%, is about 20 years, okay, is about a decade worth of living. Normal aging, 0.2 microns we're losing per year, 2 microns per decade, okay, so 100 years of aging is going into one attack of optic neuritis. The idea is if you're at 80 microns and another 40 microns gets you down to levels of blindness, we need to preserve a whole bunch of nerve with neuroprotection to make sure that you don't have on your natural slippery slope a drift into vision loss. So in summary, OCT is a high-resolution imaging tool. And you use that high-resolution imaging tool to be a sensitive measure of optic nerve injury, which is quantitative and also correlates with vision. Finally, OCT can identify retinal pathology that can help us monitor the side effects of certain therapy and also evaluate for novel pathology associated with MS. And the future may be that we can provide better diagnosis of MS in terms of activity, prognosis in terms of how people are doing, and we can monitor and develop novel therapies. So thank you for your attention, and I'm glad you all could learn a little bit about this.